All right, it's 2 o'clock in the east, and so we're going to start here. And I realized that just 10 minutes before we started that I never sent out the registration. So today, after the webinar, immediately I'll send out the registration. I guess just with Dr. Kessinger doing last week's webinar, then I thought I did it. So I did send out the registration on Facebook page and on the email. So if, well, I guess if you're listening, you already have that. So it's going to be recorded either way, and you'll be able to get this from the Facebook page and on email. And right after the webinar as well, I'm going to put out the quiz so we have it a little bit early. We've got a Memorial holiday in there in the U.S. And then also I'm going to put out next week's registration right away. And I also have a video. I'm going to post it up to the Facebook page. I did a video about the PIL and the PLI just so people could see a little bit of the axis, and that's going to be also in this week's videos, and a little bit about this with the unconscious competent. And we see, of course, across the board with the videos as they get posted, some people are converting from, say, a toggle type adjustment. Some people are brand new, just new to the knee chest, and some have been doing it for a while. But either way, we can kind of get into these positions where we start to think too much about the adjustment. Now, we're in a class type of situation and we're being very picky. Sometimes we might say, move your hand just a half an inch this way, or rotate your hips just a little bit that way. And that's getting really picky. But what we find is that when we're real specific with all of our fundamentals and we get them down in the classroom setting and we video ourselves, then as the time comes to start adjusting patients, we need to be able to just step right into it and not really have a lot of extra thought. And Dr. Kale used to, because people would ask him, what do you think about when you're adjusting? And he would say nothing. And so what he would say was that it would be like he would get and he'd have all these thoughts around him and people are maybe near him and talking, and he would just, as if he opened up a door and walked into just an empty room. And when he walked into that empty room, then he'd make the adjustment and then he'd walk back out. So it would be this instant of just nothingness where he just drops it all and just lets the adjustment go. So he's not thinking about tissue pull or roll in or set down. And that's what we want to get to, is where we can just have all that in our mind, and maybe going into it, okay, this patient, they need a little bit more set down, or that patient got to be real light on the contact, and you have all that thought in your mind prior to the adjustment. But then when you actually make it, all that has to leave your mind. So I'm going to post a video up here as soon as we're done today. It's just a 6-minute video I made talking a little bit about that as well too. So let's go ahead and get into it here as soon as I can get my thing going. We're going to go through the quiz, and then also there was a case that we were talking about on Facebook. I just want to go through a little bit. It's kind of a little bit more of an x-ray detour, but that's okay. We're still staying within the same topic. So we have to make sure that obviously that the reading, the x-ray is proper, the readings are proper, because if you have great adjustments but they're at the wrong time or in the wrong listing, then we still don't have a whole lot there. So what determines, the first question here, and most everybody, I'll get these quizzes back here later today because I was going through them, and pretty much everybody nailed most everything, so that's good. And really, when you watch the videos, some of it you might know beforehand, and when you watch the videos, the answers are there. But what determines the character of the C1 misalignment? And this is really important to get, and I know for a lot of you, okay, we've done this 70, 80 times, and that's what we say whenever we ask a quiz question or we have a quiz, then this will be in there pretty much. because it is critical for us to understand that you got ASLs and you have ASRs and so on and so forth. But every ASL and ASR is not exactly the same, and that characteristic of the misalignment is going to be determined by the track side. So we want to think of it, and you can hold your hands out in front of you to kind of see that there's a slope, there's a convergence, and a convexity there, and all of those factors are going to come into play. Now in this case, if we're judging off the left, this would be, ASR, and now we want to know, okay, what's our slope, what's our convergence, what's our convexity on that track side? Because what it is on the track side is going to determine how much rotation, how much anteriority we may actually have in, say, an ASR. So it's important for us, and as we look at our bones and you see the sloping, convergence, convexity, to understand in a certain ASL, ASR, and I'll show you later today when we look at the films here from that case, you can see a little bit of the same thing to judge, okay, am I going to step out? Am I going to lean over? Most of them, we're going to want to stand in that cardinal straight up position, but even so, is the atlas real close, looking at the lateral, real close to the skull? Is it dropped down real low? So sometimes we have a lot of anterior and superiority, and we do not get low enough on our contact. So you're a little high on it, and it still moves, and there's an audible, but not so cleanly. And a lot of times when either there's no audible or it's just doesn't feel like a real good set, then the two main things we always want to look at are contact. Now, of course, that means you got to be on the right listing, but that your contact on the bone was good, and then set down. Usually those are the two things. Now, of course, if, say, the patient's not positioned right, maybe their neck's not all the way flat on the table, so you're going to have an air gap, and you set down really well, but really, if you would have set them properly, that set down would have been perfect. But because their head and there was a gap in there, you would have had to set them down further to get that flat. So in the end, most of our problems where the bone just doesn't move, or we don't get an audible or a really bad set, tends to be the contact is not good and the set down. So with the tracking and sliding, we just want to get this understanding, and Dr. Blair brought this forward where it's going to slide on one side and track on the other side. And the only thing that we kind of altered to that a little bit is these aren't really a straight line because of the curvilinear misalignment. Then it's going to go in a curvilinear torquing fashion. So with the PLI axis listing, where is the pivot point? And this is what we're getting into a little bit more, is this week is the PLI, or the axis listings. But so what we want to understand, the C2, C3 facet articulation on the left or right, it's going to misalign, and then the other side's going to pivot. So if you have, say, an anterior axis, an ARS, well, then it's going to be going and sliding anterior and superior on the right side, but then it'll be pivoting on the left. And in the opposite of that, if it's a PRI, then the spinous process is rotating to the right. So to get there, it's going to have to slide on that C2, C3 facet, and it's going to pivot on the right side. So you just want to kind of get that into your understanding. See, if you look at these two over to the right, let's go back there, right here, these are exactly the same. They look exactly the same. Now here, we're going to call this, in this upper corner, an ARS. So, but we know that really because of what the arrow is showing. But if you look at the two vertebrae, they look exactly the same. And so if it's sliding on the right and pivoting on this side, then we have an ARS. If it's sliding over here and pivoting on the right, then we got a PRI. So we want to get that understanding, and as you make the adjustment, we want to get that understanding as well for our contact point, and just visualizing in our mind. It is important for us to have these biomechanics in our mind before we're making the adjustment, so we know exactly what we're trying to achieve. But then again, like I said, right before the adjustment, we really want to clear everything out of our mind. So what are the three factors that determine the shape of the condyles? And the three that we're looking at is this convexity, the convergence angle, and the slope angle. So the convexity, the occipital condyle is a convex surface from A to P. The atlas lateral mass wraps around the convexity of its respective condyle. It's the convexity of the tract side that helps determine the amount of atlas rotation. So the greater the convexity, then the greater of that rotation. The same thing is going to be true with convergence. Now we usually can see this from the base posterior view, and when you see that convergence angle and it's a higher convergence angle, we know there's going to be more rotation. The thing that we do need to remember is that if that vertebrae slides to the right, this is an ASR, no matter what, because of how the tracking side is, it's going to have to go in a clockwise fashion. So that vertebrae is going to have to go. Now, to the varying degree, that can tell us if it's very straight in the convergence angle, it's not going to be perfectly straight, but if it's straight there, then of course instead of curving a whole lot, it might move. It's still going to curve in that way, but more anterior, causing us to stand out further from the patient. And that's traditionally, people might call that an ASRA, but we call it an ASR2 because really the vertebrae is not going to move in an ASRA fashion, to be specific with the wording. We had a question on that on the Facebook page as well too. So to go through that, we have that fourth listing that people add in a P or an A, and to a degree you're going to have some of that. But what we're looking at is remembering, like I said, with the ASR, the way it moves, and if it slides to the left in an ASL fashion, then it's going to have to rotate because of the tracking side of the right. It's going to have to go in a counterclockwise fashion. So you're going to have an ASL, but what happens is because of malformation and different things on a base posterior, that vertebrae may look like, and let's see if I can draw my atlas that's supposed to look like an atlas and looks more like a boat, but I'm getting the ballpark. But see, then, if it did and you saw a situation where, and once I get a pen like Dr. Kessinger has, I don't have to use the mouse, and I'll be drawing a lot better than that. So, it looks like when you look at something like this, that it's actually anterior on that side. But really, when you dig into malformation, it's not going to be anterior on that side. But when you see this, it is likely that maybe that tract side, that we're not seeing a lot of convergence, and maybe there's not a lot of a slope angle. And so this vertebrae as a whole, while it's rotating that way in subluxation, it's moving more to the anterior, causing us to need to step out, which would be in the traditional fashion that someone would be adjusted, an ASLA. So I hope that makes some sense, and I think a lot of you got it, but just so you can get through. So, there technically, we want to be technical with our words, there just isn't really, an ASLA and an ASRA in that sense, but it doesn't mean that sometimes we don't have to step out from the patient and make that adjustment. So this is the three. We got our convexity that we're having there. We can measure the convergence angle with the base posterior. Usually it's best to kind of see the slope angle with a protractive view. So technically, if you're just taking the AP and lateral, there is ways you can kind of get in the ballpark to guess if it's a little bit more, probably more of that rotation in there or more of the interiority. But what we find usually is the best, and a lot of times I'll do is I'll keep it in the back of my mind that I look at that and I say, okay, it's an ASR. I'm thinking this might be one I'll need to lean over on, and sometimes if I have the evidence, I'll go ahead and do that. A lot of times I'll stay in that cardinal position, that ASR 1, and that you're pretty safe, in making that adjustment, and they'll do better. But you can tell if the adjustment seems to not set quite as good as it should. Then you go back to that and you say, yeah, I was kind of thinking I need to lean over. And then you lean over, and when you grade yourself in a scale of 1 to 5, the first adjustment was like a 2 or a 3, and then when you got to that leaning over position, then it just set in there nice and cleanly, and then you write it on your stats and you make sure that you do the same adjustment again. So without the protractors and the base posterior, I would tend to side away from trying to just guess on that. I would really go ahead and make it probably most times in the cardinal position, and then based on the readings and the things that we're seeing, make the change. If you have it, the base posterior and the protractor, so you could do that right off the bat. Who developed the dentate ligament theory and where they published their work? And this is, of course, John Grostic, and in the Chiropractic Research Journal. And so we definitely want to, give credit to those. And what we found throughout the KCUCS, most stuff that we say we brought forth in the KCUCS is not actually the facts that we've uncovered. We found that from different people like John Grostic and Punjabi and White and different things. But what we've done and what we really want to do as knee, chest, upper cervical doctors is take the science and the information that's out there, but then apply it to our work, because nobody else really knows. And even if, say, John Grostic, well, he's not a knee chest doctor, so applying his work to the knee chest might not be as easy for him as one of us who is doing the knee chest work. And so for us to bring that forward, when Punjabi and White, and they are, or one of the people who brought forth the information on the medullary lock, they're looking at what ligaments and what's going on in there, but for us to apply that to the knee chest is important. So when we go through the medullary lock, it comes in a future video and we'll go through this. But what we do see is that, and this is down lower in the cord, and so they're a lot longer, but what you get is these, when it comes up into the upper cervical area, and then we see those dentate ligaments as shorter and fatter, and what they're doing basically is keeping this brain stem, upper spinal cord area in a real fixed position. And so when we start to see that torquing subluxation, it will start to cause disrupt to the cord in that area, and the dentate ligaments that are there to provide all that support and stability are working great when the vertebrae is in position, but they're also causing problem when the vertebrae is locked out of position. So that's why it's critical for us to not allow a patient to be subluxated for a long time. The longer they stay subluxated, the more that there's pressure occurring there, and the longer that we're seeing this accumulating of destruction. So in the reverse, though, and what we usually find, though, is oftentimes this sense of over-adjusting. You got to remember, when we adjust it, we're kind of overriding what's going on in here to unlock the torque subluxation. So if it's truly locked and we truly have a subluxation, it's time to adjust. But if we're adjusting it when innate is trying to make the healing and trying to correct things, then we're actually making the patient go backwards. And so we want to make sure that if our instrumentation tells us, despite the symptoms or whatever's going on, that the patient is trying to hold their adjustment, we need to leave it alone and let that healing process take place. And so I know most of you have that, but it really cannot be said too much, because we have to make sure we are not the healer, and we know that, but that we're not interfering with the healer when it's taking place. But we do have a job that we've been called forth to do, and that's whenever there's a subluxation, is to make that correction. And this is what we're trying to do here, is learn to be as efficient and be a master in that. So when called upon, there's really relatively few people in the world that can properly adjust the atlas. And so it's important as we learn that, and as we go forward bringing this science forward, that we get to the best of our ability, but we're staying within the philosophy and understanding that we're just using that adjustment when it's needed, and when it's not, we're leaving it alone. So these are the 5 concepts, 4 of which were developed through the KCUCS, that define the knee chest advantages. And so a lot of these, and people will say, well, what about this procedure, this upper cervical one or that? And we really don't have anything negative to say about any of them, whether they're orthogonal type or a toggle or whatever. The major difference, though, that we do see, and each person would have to determine on their own, and when you start to study, we're looking at the advantages of, and what it comes down to, one is that posterior arch contact. So there isn't any other specific upper cervical procedure that I know of that is on the posterior arch contact. So that does make us different. While AO is different from Grostic and different from Blair, and they're all different, they all have a commonality of that transverse process. And in knee chest, we're on the posterior arch. So it does make your reading of your films a little bit different. It makes the contact points obviously different. And so you can't necessarily take a listing from an AO doctor or a Blair doctor or somebody and just translate it 100% onto the knee chest table, because you're adjusting on a different contact. But what we are bringing forth with what we're doing are advantages of the knee chest work. And so because of the curvilinear misalignment, being able to adjust on the posterior arch, we believe, gives a great advantage to correcting and unlocking that curvilinear misalignment. Of course, the paradoxical motion and this coupled motion that allows to, when a person turns their head, what we get where the vertebrae gets even more in a position of locked out. And we had someone ask a question earlier, really on the set down, and what we're trying to get through all of this, through rotating the head and the atlas is going down the hill, paradoxical motion, and when we add the coupled motion that's actually adding more rotation to it, then the vertebra is getting in a position where it has nowhere else to go, and when you set down and traction the rest of the cervicals, then at that point, the very next thing that happens, the adjustment, it takes very little, because everything is kind of taken to this end point, and just the least little movement at that point can make the adjustment. So what you'll find through time as you get doing this, the better that you position that patient and get their head in the right place, and they got a little bit of extension on their neck, and they have some lateral flexion because of the table, and the shoulders are in a relaxed position, the neck is flat on the table, then when you're standing in the right position and you make that set down, it takes very little after that to make the adjustment. And so that's what we want to start looking to, and continuing to make the adjustment with the least amount of enticement needed to get innate to set the vertebrae. And then of course the medullary lock, that whole theory was completely brought through from the KCUCS, but using anatomical and physiological facts that were uncovered by other people, and then we put it together for our understanding for the knee chest work and the upper cervical. Really, it's a philosophy through the just upper cervical subluxation. So what is probably the most important step to get right when adjusting children? And so most everybody got this right, but this is really, if I was going to do one thing, it would be the set down. So if you can't get the child on there that good, or they keep bringing their arm up, or they're crying, or whatever it takes, in the end, I'd make sure that set down is complete and full. Now, kids have a lot of flexibility to their neck. So you can almost see here as Dr. Patrick is setting down and pressing. He's using a finger contact, and then he's using the other hand as the hammer hand, and he's pressing downward. And so he's going to, again, put downward pressure there, and it's actually going to even traction the shoulders a little bit. But you got to remember, the kids are super flexible. So when, and then when you're starting out, you may think like you're afraid to really, get in there. But it's going to be in a split second, and it's not going to be painful to them at all if you quickly set down to where you've completely, there is no more room to set down any further. Their neck's completely, you've gotten to the end point. So once you do that, then you make the body drop, and you come in that downward spiraling arc, and it just sets very easy. You're going to get an audible, and it goes right through there. So I have a couple videos here, and we'll show you. Hopefully we can see the set down some on this. So we're going to go into slow motion here, and there's the tissue pull, and should have probably had the thumb down the spinous a little better there, but we're going to get it, and I'm kind of setting it down right now, and then you see we just at the end, I'm going to traction down just a little bit, and then the thrust comes right after that. Of course, in slow motion, it always looks like so much more, but it's real easy. Doesn't take a whole lot, and parents are actually really kind of surprised on that. And so here, this one's actually a little easier to see, and you could probably see it there in the fast motion. And let me get one here in slow motion. And I'll post these videos up on Facebook too, because sometimes they're hard to see in the webinar. But what we see here is right before I go, you'll see I'm set down right there, and I'm going to set down here in just a second. And there it is. You can see it kind of brings those shoulders down, and then the thrust comes right after that. And so sometimes a person mentioned on the, looked like the person slid down the table. Well, if they were kind of up the table a little bit, sometimes when you set that down, then you'll see they might even slide down the table just a little bit, and that's okay. What is the patient position for an infant? And pretty much, again, everybody got this right. What we're looking for is really just to be on the table all the way, because of course they're too small for their knees to get on the floor. So we just lay them, and then at what age is it appropriate to adjust the child? And of course that's going to be really as soon as they're in pattern. So it could be right away, and for some people it could end up being a couple years even, depending on when they actually come into pattern. So here's a visual of that. The baby's going to be completely lying up on the table, and just like that. And again, what we're looking at here is you got the finger contact, and the other hand, the hammer hand on top of that, and then it's going to be set down, and it's going to even with that kind of traction the shoulders, and you can see she's got a big grip. Well, he in blue. So it's got a big grip on the towel there. So give 3 points that are helpful in performing successful infant adjustment. And so again, the number one thing is really this set down needs to be complete and firm and full. Light contact. So the longer that you spend taking time and the more that you press in on it, then the more difficult the child's going to be squirming. But a lot of times they may just lay right up on there and it'll be fine. Then if you're very, very light in finding the atlas and rolling in, it's not a big deal. Now, right before you go, then you got some force going. You're putting this full set down, but immediately after that, the adjustment comes. So it's really just that last split second, and they'll hear that audible, and that'll oftentimes make them cry. But what we'll see is they'll cry anywhere from like 1 and to literally maybe 5 seconds. If they start to cry for 10 or 15 or 20 seconds or longer, chances are it was a little bit too hard. So you can tell with that when they hear the audible and they kind of let out a cry and then they just immediately stop. This is usually a very good adjustment, and it was just the audible that they heard there. Make sure that we do that abdominal contraction. It's very easy with the children to just get in a situation where you only use your arms, and while the vertebrae is very small and you can do that and get an audible, it will not be as efficient or as clean of an adjustment as if you would have used the body drop. So when should we have the child kneel for a knee chest adjustment? Usually this seems to come about age 6 or 7. Really what you want to find, and sometimes I'll put the pad on top of that piece that on a Kale table has Kale's name on it right there, and we'll start them kneeling down with that, and then until they can move to the floor. But if they're kneeling on the floor and it takes a lot to get their shoulders and neck up on the table to where it's not really flat on there, they're too small and you have to wait a little bit longer. So there's a point where you just lay the whole body. Then there comes a time when they're standing on the floor but their belly is laying on the table. Then comes a time when maybe they can kneel real close to the table, and then obviously later. So the main thing is to get everything in the right position so that we can get the least amount of force. Again, like we saw last week as we went through there, everything that we're doing in the patient positioning is really geared towards being able to use the least amount of force possible. So how would you define the adjustment with the extra something? And I hope that, I thought this video came out pretty good when we talked about the adjustment with the extra something. I thought it was good to see the different perspectives there. But this is kind of what BJ said, and what we see is that when adjustment becomes habit, when you don't think, it's just a part of you. So we need to start getting to this point, and it really comes at first being the conscious competence, so where you're thinking about it and you're starting to get all your fundamentals working for you. But what BJ was saying is when you don't even have to have a confidence. And what he's talking about, a lot of times people have to almost talk themselves into, I can do this thing, I can do this, and they're really talking themselves into a confidence. So what you have is when a person is getting to making these adjustments with the extra something, it's really just a part of them. So at that point you just make adjustments, and you're really not thinking about, can I do this, or I'm good at this, or I know I can do it. And as I said from years back on Saturday Night Live, I'm good enough and smart enough, and doggone it, people like me. So you don't have to really go through all that. It's just become a part of you. And some of that really, it just takes some time and then videoing and making sure that you're checking your slips. And then oftentimes, even for myself here, when we make videos for the boot camp, and I'll say, hey, I'm starting to do this, or I'm starting to do that, and then you want to correct that, because at any point anybody can start to slip back. So you want to always stay on the craft. So the specific scientific chiropractic adjustment is delivered with the correct intention to the patient in the knee chest posture. It becomes second nature and automatic, a combination of habit and intent. And a lot of times people focus on intent, and it is important, but it's not just that you intend for a good adjustment or you intend for the person to heal, and that's going to happen. But our intent will have, a lot of times we'll get what we focus on. And so that's why it's important to set goals and to have something to focus on, because your body, and Dr. Kessler goes through this in the neurology boot camp, how through the amygdala and how your body will try and bring into your real world, your brain will try and bring in to the real world what's going on in your brain. And so when you are focused on getting sick people well, and you've studied the medullary lock, and you understand the curvilinear misalignment and how the bones are shaped and how they move in subluxation and how they move in correction, all that stuff is being placed into the computer of your brain, and your focus is right. Your focus is correct when you're focused on the fact that I've done my pattern work and they are in pattern, and I know for a matter of fact they need to be adjusted today. Well, they feel fine today. It doesn't matter. Or they don't feel fine, or whatever it is. You know, because of your good work, what needs to happen. You know how to do it. And once you've put all that stuff in there, intent is right, and you're ready to go. And that makes a big difference. That if you want to be able to make these adjustments where people hold for days and weeks and months, it comes to putting it all together and having your mind right with that. And that's why also you do want to try and make sure you're not going into adjusting people where you're distracted mentally as well too, and when you're in complete focus of what you're supposed to be doing on that day. And so when we get in that state, the adjustment just really becomes second nature, and we get to this unconscious competent. So, and later today, like I said, I'm going to post up a 6-minute video about just the first part is really about tissue pulling for the PLI and PIL, but then the second part just going a little bit more into that unconscious competent. So the adjustment, which becomes second nature, is preceded by a still moment. This we were talking about earlier with Dr. Kale. He would say where time and space vanishes, to let room a deep sense of being totally in presence at one with the bone. That sounds, maybe a little weird or whatever, but it's not necessarily. Really, it's just clearing your mind. And what you'll find in most of athletics, and when they've tested, they'll find that, just for instance, say, the mental activity is going crazy like this, and then when the mastering performance happens, then the amount of information that's happening in the brain is almost none, and then when it's done, then it starts to move a lot, and we get a lot and so there's this calming, quiet period where everything is clear from the mind, and that's when the event happens. And so that's what we need to look for. You want to get to where you're not thinking like, okay, 1, 2, 3, go, or sit down, or whatever, where it's just happening. And Dr. Kale said going into this empty room, and that's where he'd make the adjustment. And the adjustment, the extra something, the other thing, it has staying put value. So when an adjustment holds for days or weeks or months, this is when we can say, and BJ would say when someone says, is that a good adjustment? A lot of times he would say, well, I can't tell you now. I'll have to tell you later, because we have to see if it had staying put value. And so to bring that forth. So I want to spend the last bit here and go through this case. And what we had here, these films now that were taken and they were viewed, and it was given a PIL listing, I believe, and that may or may not be fine. I don't know the Blair technique that well. We use the Blair protractors, and so to have a Blair adjustment in this case on PIL may or may not be efficient. I would look at the graph, but we're looking at this from a knee chest standpoint. So when we look at this, many of you have done the X-ray boot camp. So what we're looking at, just to start with, we got an AP and a lateral here. I blew that AP up pretty big so we could see it. And just to quickly go into this, we want to see is the dens in the center. We have 5 steps. What we use is visual, primarily visual analysis without drawing lines. And so the dens, it does appear to be close to the center, but what it does is it does lean just a little bit to the right. So you may take that into consideration, that potentially the gap between the atlas and the dens would be less on the right if the dens is leaning to the right. So, but it's centered enough here at the base that I'm okay with saying it's centered in step 1, understanding that lean. And then we want to see this atlas and dens space here, and of course we're seeing a much bigger space to the right, and so that's going to give us another factor there for ASR. Now when we look at this, and you have to look at these films, and I change the contrast back and forth, you can see the foramen magnum a little bit, but you get right into the teeth, and it's a little difficult. But that one as well, if you were to mark and could find your foramen magnum out, then you would end up seeing, even with the arcs, and that the atlas is to the right of the foramen magnum. When we get to step 4, we're looking for overhang. Now there's no overhang on this corner. It's actually, if anything, maybe a little bit less. On this side, probably about equal. The thing that you get when it's almost, say, and I don't know what you want to call it, underhang or whatever, but not overhanging and not even matched up. We see a lot of times that this, if I don't even see a lateral and I see that it doesn't meet the corners here, there's a good chance that this is an anterior, as far as that bone is moved quite a bit to the anterior, and that's why we oftentimes see that. So it's just, that's not even a rule or in anything. It's just something that we oftentimes see. So when you're seeing that, and you see that, and we'll exaggerate it out here, that the corner of the axis is here and the corner of the atlas is there, and just exaggerating it so that we can make a point, and it's like that. This atlas, before I see the lateral, I know that it's anterior. It's gone forward on that some when you see that. So that gives you that ballpark. And there's a lot of other stuff we can look on the AP open mouth to just see through there, and look at the spinous of C2, and that looks like it's moving somewhat to the left there. So looking at all of our stuff and the overall look, to me this looks like right laterality with a left axis laterality. So that's where we're starting on that. Then when we look at the lateral view, what we see here is, like we said, see how that anterior tubercle is actually kind of pulled away a little bit, and then measure that out. I don't think that's as significant as far as something where you'd start to classify this as any kind of disease, but it is, maybe there's transverse ligament disruption. Maybe this person had rotary cervicals. Usually, if there is any difficulty with the transverse ligament that's not, a disease process like rheumatoid arthritis or Down syndrome or something like that, of years of deterioration, usually what we see is a lot of rotating cervical adjustments chiropractically that can cause that, and maybe a number of significant auto accidents. I wouldn't, go on the auto accidents here. We're not seeing a lot, but maybe there was that. But it's not as far as the rotary cervical adjustments, but it's not so severe. The thing that we do see, though, anterior tubercles here, that it's definitely superior. So if it is superior there, then of course you can't have posterior superior with the atlas. You'd have to have anterior superior. And so when we see that, we're already thinking that before we've looked at a protracted view that we probably have an anterior superior, and a lot of times when you measure that out, this measures to about a 17-degree angle there, and so you're not really going to see posterior inferior unless it's really in the low numbers, maybe like a 4 or a 2 or a 0, or in the negatives is even more common with that. So from the first two films would be probably leaning towards an AS R, and with the axis is posterior and inferior, and maybe a PLI. So when we look at the protractors, this is what can throw us off sometimes. There's a lot of activity going in there, and just to show you, of course, if you haven't looked at many of these, the atlas is right in here, and the occiput, right, occiput and atlas right there. But you have a lot of other stuff going on. See, this is a big sinus that kind of runs right through everything, and then you have a lot of other smaller densities through there, and sometimes those can cause problems seeing what we're wanting to see. When we look at this, we want to, and as we've gone through X-ray boot camp, follow the posterior arch. We can follow on the atlas, and then that will lead us to the transverse process, which will lead us all the way up to the, as best I can do it there, the atlas. And so because I knew I was drawing on my mouse, I drew this out here. So here's our posterior arch, and here's following it through there, and then got off track here. We'll try this one more time. There's a posterior arch, and so then when we follow along the condyle, we're looking for where that turns, and let me kind of blow this up to make it a little bit bigger so we can really see it. And so what you get, this ends up being matched up in the posterior arch, and we follow along in the corner of the atlas, and then as you come up the occiput, right there's a place where that turns there, and so you wouldn't want to take this all the way up there, all the way up into the corner, but when we look back right here, let's make this a little bit bigger, and you see this white line actually carries past that, but you can see there's a place where that turns up in there. So when you get these films, you can kind of look through there, but this is pretty clearly, most everybody would think is thinking that it's matched up, and that's not our biggest issue. It's really the right side that becomes the side that we're wondering about. So you're matched on this side. Now remember, and we can see our slope angle there, we'll get back to that. Now the right side, this is a little trickier. A lot of times what we're looking at here, you got to remember, so sometimes you're looking and you're thinking like that occiput comes up here and the atlas is under, so it's gone down. Now we know from our lateral and everything that this isn't inferior, so it's not posterior and inferior, but we're going to still want to mark that out. The thing that we see a lot of times, especially like you see this white piece right in there, that kind of crosses the joint space. So we know that that right there, right here, is not really part of the occiput because it's not going to come up and turn in the other way just like that. The other thing that we have throughout here that we got to keep our eye on is we have a lot of sinuses. So we have something right in here, kind of just like that almost, and there's a number of different densities. It looks like one right here kind of comes across the whole joint right there, and so when we look at that, we got to remember that you got to see what you're seeing when you're seeing it, and there's a lot of other stuff that's crisscrossing. See how it's getting dark right in there, and part of that is from the sinus that's just overlaying on that. So I did change the contrast, and you want to do that some. See, this contrast even shows how it causes a black line right between our atlas right there. because of that extra overlaying part of anatomy. So our posterior arch here, and you can see the other side of it right there, and then we follow through, and this is where our atlas, and pretty much that's kind of easy to see. The problem is a lot of times where that occiput goes, and so if you look at, and you can kind of see where this line comes up, that's the occipital condyle, and there's a little bit of a break in there. I can tell you I moved this to a lot of different colors, but to contrast, but to really see it was difficult. And again, like I said, we're getting a lot of other stuff coming through here, and you have different densities of stuff that's actually, another thing right there, and then there's a big one that's right there. So all that stuff is really coming right over top of all of our work, and whenever you have something like right there, that comes right over the occiput, and it's very, very difficult to read. And so let me see if we can make this bigger, and you can kind of look in there and look through that. So even on this one, we see an overlap really to the right, and so that ends up giving us that ASR. And so again, what you're looking at is really how this comes up through there, and you're not wanting to follow this, way back or wherever, because that's part of this sinus that we see over top of that. So I hope that makes that clear. Now when we look at this case specifically, here's the base posterior. Now we can also, we have a base posterior protractive views. You can look at it. Here's the transverse foramen, and with my mouse, so this isn't going to be a straight line, but we're trying to go through there. So this, we're already saying ASR, but that looks like it's going quite a bit more that way. There may be some malformation. We see how anterior again the atlas is when we see it on the base posterior. But then when we look at our convergence, let me get this as best I can, just like that, it seems as if we have a pretty strong convergence. So we got that going for us, and then we come back to here to our left side, and we see a really steep slope angle. So this is one that I might right off the bat, now I'm not going to lean so much, but I might then try and go ASR and then just lean over a little bit, ASR 3. So hopefully that, and then of course if there's more questions, put them out to the Facebook page, because I want, if we have more discussion. But I think a lot of you have been in the X-ray boot camp kind of see that, but it was interesting because we saw it without seeing the open mouth, and people thought it might look one way. Then when they see the open mouth, they say, okay. But when I first looked at that, even on the protractos, I was thinking this is probably ASR. Nasium's hard to judge from, but I was like, let's see what that open mouth comes out to, and it did how I thought it would. So I'm just going to hit a couple things real quick on the tissue pull, but like I said, putting out another video on this. So this right here, just want to kind of show, let me get a pen if I can. And one of the things I want to get with, when we do the tissue pull, we're going to be tissue pulling in the way that an effective torque would be, but we're not actually torquing our arm. So remember, that's how you tissue pull. Now, when you tissue pull too, we're just tissue pulling a half moon. We don't want to pull the tissue so far that we come all the way around. So just pull right in an arc up to the atlas contact point. And so that, in say an ASL, is going to go in that fashion of how I just drew it there. And so then what we're looking at was, say, a PIL. See how that kind of comes under? So you're going to just pull just a little bit this way again. And so that's the opposite direction. It's affecting as if a torque is this way. But what we don't want to do is really use a lot of our body or forearm or whatever to really do a big torque on that. So I just want to wrap up here and just have a couple quick videos on the set down just to show what we're talking about, and see if you can see this. This child's moving around a bit, his arms kind of, you know, moving, and so at the end, it's right at that brief second, and we'll show you here in right at a brief second, I'm going to press down right there and then go. So right here, everything is now taking complete tension to where we've firmed everything up. This is just a different angle of it. And you can see as we'll traction the shoulders down here and set it down, we're kind of getting that contact firmed up. Then right there is where we've set down, and then instantly afterwards then comes the thrust. And so I think pretty, you know, well, you're catching that, but just it's easy to do a partial set down. And so what you really want to do is really set that down, and you'll be able to see almost like the head almost comes up a little bit, the shoulders come down, and it firms that up, and that's what we're looking for. And so I'll go ahead and post these onto the Facebook just so you can see them in the slow motion and work with it. You guys are doing great so far. I'm seeing phenomenal videos, and of course when we make comments on the Facebook page, remember these are just really small issues. Sorry about that, got bumped off track. These are just small issues with the adjustment, and so they're actually many of these are just nearly perfect. But when we're in a teaching setting, if we see like just one thing, you're, you know, a half an inch this way or that way, we want to point this out. But remember, we're not trying to point this out to get you thinking too much. So just see it, realize, okay, yeah, I see that, and then just, you know, let that incorporate naturally. The videos we're going to send out here, C2 Biomechanics listing with Dr. Stance's advantages of the knee chest adjustment through the KCUCS, what we brought forth. The secret sauce is revisited. Dr. Kester puts together another short video on that. And then the audible video is really for later, but I'm going to bring that in earlier because we've been talking about the audible so much. So I appreciate those of you who could be on it with the late get together of the registration, and we're going to send all this stuff out quick so that this week we get on top of it. And I appreciate everybody, and we're, you know, getting towards halfway, so make sure you keep on pressing forward. What I see in the beginning is I'll get 80 or 90% of the quizzes back, and by week 4 I get about 20%. So try not to give up, try to stay in there and hang on to persevere through the end. All right, I appreciate it, and we'll see you on the Facebook page.